So the newest, I think folks on this call, many of whom are one-up customers, know all about 0057 and the APIs. But what is interesting there is there is still work to be done in that 0057, and they signaled that back in 2024. Well, 0062, which is proposed, really fleshes out some of the missing parts in 0057. The biggest thing it fleshes out, again, this is a proposed rule. It could all change. It could never be issued as a final rule, but it will be issued as a final rule just because of the inertia of the things in the rule and where it is on the political calendar. The two biggest, let's say, are really nailing down the fire protocols and specs for all these APIs. They were mostly left as advisory things. It would be great for you to do that in 0057. Now they're being proposed to be required. The other big thing in prior auth is getting prior auth to drugs. This is big because prior auth, a lot of the most expensive things now are actually medications. Many of these, especially autoimmune diseases treated with complex monoclonal antibodies, are very, very expensive medicines. The interesting complexity here is it's being addressed in two separate parallel pathways. So one pathway, which is the prior auth of 0057, is having for medications that are a medical benefit. So now we're talking about, for example, IV administered antibodies. Those are using the whole FHIR Da Vinci prior auth protocol. Prescription drugs are going through the NCPDP, which is a pharmacy trade group protocols that you're currently using to get prescriptions from provider to a pharmacy, often done by SureScripts. And so you have what are called medical benefit drugs on the Da Vinci FHIR prior auth protocols. You have prescription drugs that are pharmacy benefit, Part D drugs, if you will, for Medicare purposes, coming on NCPDP and those protocols. So, and then prior auth is part of both of those things. So payers will need to sort out how they deal with both of those things and making sure they have the data stores to do that. The interesting stuff on the FHIR standards are they're now really being required of everybody, providers, plans, clearinghouses. The attachment standards for some of the attachments are using CDEX, the clinical document exchange, which actually does include older things like PDFs, images, and continuity of care document architecture, clinical document architecture, which is a XML standard from about 15, 20 years ago. So there's some variety there, and those are going to be requirements in the 28, 29 timeframe, depending on the pieces. Another big part of enabling all of this digital is that payers are going to have to report their endpoints very promptly to the National Healthcare Directory. So that's a requirement, and that requirement will probably hit within 60 days after the rule is finalized. This rule could be finalized, I would say, as early as 3 months from now, 4 months from now. I think it's coming soon, and that will include APIs, all of these APIs that we've been talking about there, and FHIR capability statements. So where before CMS didn't really have effective enforcement tools, now this is going to report to the directory, and you can just run a bot to see who's in compliance and who's not. It becomes a lot simpler.